please. Thank you. Thank you. I would like to welcome Dr. Anant Nigam, who will be giving the next talk. A personal friend of mine, Anant Nigam, I've known him for over now 32, 33 years. In fact, he was one of the earliest one, along with Dr. Shaukat Sadikot, myself, who actually contributed to Diabetes India starting way back in 2001. He was the Secretary General and did a lot of work for almost a decade before he decided to just concentrate on his practice and take a back seat from the administrative part of it. So I welcome you, Dr. Anant Nigam. His career in diabetes spans over 38 years. He was the founder of Diabetes India. He was the CEO for almost a decade, a fellow of the Royal College of Physicians. He has delivered orations, invited lectures, keynote addresses. He has chaired scientific sessions at most of the international and national conferences, including IDF, ADA, and other meetings. He has indexed national and international publications and chapters in API and RSSDI textbook. He has served as an expert for ICMR project, was the chairman of the organizing committee of the National RSSDI 2003 and Diabetes India in 2005. And he will be giving his talk on the use of once-a-week GLP-1, the multifactorial treatment, and the uses of it. Over to you, Dr. Anant.
Thank you, Aravind, for that kind. Give me the permission to share my screen, please. Yes. Yeah, thanks, Aravind, for that kind introduction. And let me thank Diabetes India for this invitation. And Bansi, I can see here. Thank you, everybody there. We all know that glycemic control really improves the risk of, reduces the risk of complications, and the landmark trial UKPDS really showed us the way. But then, did glycemic control do everything? That was a question which bewildered researchers all over the world for years. And the STENO2 diabetes study was again another landmark study which showed that multifactorial intervention probably has been shown to reduce both cardiovascular death, cardiovascular events, and several other micro and macrovascular complications that one is likely to get in type 2 diabetes. So the whole paradigm now has shifted again in this direction with the arrival of new agents like the GLP-1s and the SGLT2 inhibitors. And in fact, all these guidelines have been rewritten. Do we have evidence with the GLP-1 Dulaglutide once weekly is something that I'm going to convince you. Now, we all know that type 2 diabetes is a cardiometabolic renal disease with multiple complications, disturbing metabolic homeostasis, giving rise to CV events, renal complications, and cardiovascular complications being responsible for 75% of hospitalizations, 65% deaths, and the trio of type 2 diabetes, kidney disease, and cardiovascular disease is called a triple threat. The risk of cardiovascular disease in people in India with type 2 diabetes, this is the Cures score 3, which shows your chance of getting a heart attack in about 10 years from now. And this shows that this risk is increasing both in men and women as your age advances. But this is not all. In people with type 2 diabetes, and Asian Indians have a massive disease burden. They have abdominal adiposity. 70% of them are hypertensives. 2 to 4-fold increase in the risk of complications as compared to your Caucasian counterparts, and 40 to 70% increased risk of renal complications. And this India Today title was in 2006, The Girth of the Nation. And this is exactly what we find in our clinic data. You have abdominal adiposity, men more than 90 centimeters, women more than 80 centimeters. You can see about 40 to 50% of urban men and women are obese centrally, also having increased body mass indices, causing obesity and central adiposity, and the amount of visceral fat in Asian Indians as compared to Caucasians is much more. And that is a pretty well-known fact. But look at what Elliot P. Jocelyn said in 1927, With an excess of fat, diabetes begins, and from an excess of fat, diabetics die. Remember that type 2 diabetes never occurs alone. It occurs in the company of bad friends, and these bad friends are hypertension, obesity, kidney disease, and cardiovascular disease. The common risk factors are age, male, high cholesterol, family history, and chronic kidney disease. But these are diabetes-specific risk factors. And you have to see that if your patient has retinopathy, he's probably that also is a risk factor for cardiovascular disease, glycemic control, and duration of diabetes. Now, this cardiovascular death will continue to increase if the number of risk factors multiply. So if you have 3 risk factors, then your chance of getting these complications, age-adjusted cardiovascular death, will increase as compared to people who did not have diabetes. What happens if I don't control my diabetes? The progression of diabetic retinopathy will continue to increase, and the time taken to progression of diabetic retinopathy will be much less. So if you have clinical inertia, your patients will get diabetic retinopathy much earlier. It causes poor metabolic control and increased progression of diabetic retinopathy. But that's not all. Look at the number of macrovascular complications that come in with poor metabolic control. 67% increase in myocardial infarction, 51% increase in cerebrovascular accidents, heart failure, and a composite increase of CV events of about 62%. If I only control glucose, am I justifying saying I've reduced the risk of complications? No. The association between type 2 diabetes and mortality due to cardiovascular disease, irrespective of HbA1c. You may have an HbA1c of less than 6.9, but look at the hazard ratio there of cardiovascular disease and mortality, which means you've got to go beyond controlling, which doesn't mean that you should not control your HbA1c. It's extremely important, and all these landmark trials have proven that. But you've got to go beyond that. Something that again bothers people when you are trying to treat type 2 diabetes is the risk of hypoglycemia and weight gain. And these are swinging on this balance. As you try and get your HbA1c down, you're pushing up the chance of weight gain and hypoglycemia. And this increases with the use of sulfonylureas, meglitides, and insulin. Does hypoglycemia cause cardiovascular risk? Well, that is always hanging there. And the data from the Accord study said probably it was not an innocent bystander, but probably the signal was there. And look at the weight gain in all these clinical trials. The UKPDS, almost 5.3 kg with sulfonylureas and insulin. In the DCCT, in the Accord trial, more than 10 kg weight, rosiglitazone and glyburide. And then look at hypoglycemia, intensive versus conventional therapy. And you can see the risk of hypoglycemia. And hypoglycemia, again, is a major limiting factor in meeting your tight glycemic controls. And this weight gain or obesity, all forms of obesity, increase cardiovascular risk. So there has been really a paradigm shift, as I mentioned in my opening remarks, in how we understand type 2 diabetes and how we try and manage in 2022. Previously, it was all about blood glucose and glucose control. Now it's about glucose control with no hypoglycemia or weight gain, but also aiming for weight loss and paying specific attention to cardiovascular risk and renal risk assessment and management. What do the guidelines and consensus statement say about it? So in the next 10, 15, 20 minutes, I'm going to answer what is multifactorial intervention, which we are going to talk about today. Does multifactorial intervention help in reducing microvascular and macrovascular disease complications in type 2 diabetes? And is there evidence that GLP-1 receptor agonists, specifically once-weekly dulaglutide, help in multifactorial risk reduction in people with type 2 diabetes and thereby decrease the risk of CVD and renal disease? The answer to this is yes. Now, this is the steno-2 diabetes that I was mentioning about, a very simple study conducted in 160 patients with type 2 diabetes who had persistent microalbuminuria. And they were put on intensive versus conventional therapy. And the intensive therapy was anti-diabetic therapy, trying to get HbA1c less than 6.5, RAS blockers trying to get blood pressure less than 130/80, statins trying to get cholesterol less than 175, and low-dose aspirin for primary prevention. The study was designed for a period of 7.8 years with a mean follow-up of 5.5 years. And you can see here, within the first 2 years, the graphs started separating. And there was almost a 13 to 20% reduction, absolute risk reduction in CV events and CV death. But then a later follow-up at 21 years, look at what happened. Secondary and tertiary endpoints showed significant improvement in all-cause mortality, CVD mortality, CVD events, autonomic neuropathy, and also microalbuminuria. And this, according to Peter Gate, was a 7.9 years gain of life. There was, in addition, a 70% decrease in hospitalization for heart failure and 69% decrease in stroke. And this study was published this was 2018, where they showed the follow-up at 21 years. And this probably has now forced or advised, this advice comes from the American Diabetes Association 2022. If you have to really look at pillars of management in type 2 diabetes, you've got to look after glycemic management. Never ignore this. You've got to tighten blood pressure control. You've got to manage lipid control and use agents which have cardiovascular and kidney benefits. You also have to very importantly remember that these risk factors should not be ignored. Duration of diabetes, obesity, a simple thing that you can measure in your clinics, waist circumference, is an important cardiovascular risk factor. Hypertension, smoking, premature history of premature coronary artery disease, and presence of albuminuria or chronic kidney disease. So just remember these 4 important things that would probably help you to decrease cardiovascular risk and complications. Now, coming to this picture here, which shows you anti-hyperglycemic agents as of today. Now, the most important ones being used are DPP-4 inhibitors, the glitazones, sulfonylureas, and insulin. But look at their risk of hypoglycemia. SUs and insulins increase risk of hypoglycememia. If I come to cardiovascular benefits, none of them give you cardiovascular benefits except being safe. They're all cardiovascular safe. Potential benefit may be pioglitazone, but we don't use that so often. And what about kidney disease? All of them have neutral effects as far as improvement in kidney function is concerned. Now, what happens with the only other 3 agents left are metformin, SGLT2 inhibitors, and the GLP-1s. And let's see the GLP-1s. The efficacy is high, hypoglycemia is low, loss of weight, and look at it gives you cardiovascular benefits. And dulaglutide stands out very typically here, progression of DKD, and also dosing. You don't have to adjust doses even in patients with chronic kidney disease. And this is the reason why guidelines are changing. Look at the ADA 2021 guidelines. Here it said you should consider independently your baseline HbA1c, individualized targets, or metformin use. But look at 2022. It says recommend straight away an SGLT2 or a GLP-1 if your patients have individualized, if your patients have ASCVD or indicators of high risk. And I've already shown you the indicators of high cardiovascular risk. I will again show you that, or heart failure or CKD. The American College of Cardiology says it should be independent of glycemic control with proven benefits. And the American Association of Clinical Endocrinology again says independent of glycemic control, but says use long-acting GLP-1s with proven efficacy. Trying to read between the lines, patients at high risk for ASCVD include those with end organ damage, like left ventricular hypertrophy or retinopathy. If your patient gets you a report with retinopathy, he's heading for a cardiovascular event. So look at that. Or multiple cardiovascular risk factors like age, hypertension, smoking, dyslipidemia, and obesity. Oh, we say, this guy is 65 years old, so I shouldn't be using a GLP-1 or a SGLT2. Well, that's a story of the past. You've got evidence that these are risk factors for cardiovascular events. Now, coming to the GLP-1s, we have these available in India, the ones in the orange. Dulaglutide effects on multiple risk factors: HbA1c, body weight, overall difference here. You can see here urine albumin decretion, estimated GFR was improved, and systolic blood pressure was improved. And this is a very interesting randomized trial where dulaglutide was added to conventional therapy and data was looked up at 3 months and 9 months follow-up. And these are so important, very common data that we see for all patients in the clinic every day: systolic blood pressure, diastolic blood pressure, weight, BMI, total cholesterol, HDL, LDL, triglycerides, fasting plasma glucose, GFR, CK, eGFR, microalbuminuria. And you can see here at 9 months, you can see the p-value. There was an improvement at 3 months and again an improvement at 9 months, very clearly showing that dulaglutide is working at all these vascular health indices in people with type 2 diabetes. And these are the baseline cardiovascular risk factors which we've been talking about for the last 10-15 minutes. Look at fat, another very important epidemic which is around, which is NAFLD. And here it shows that dulaglutide decreases liver fat, decreases gamma GT levels, improves liver stiffness, and also probably increases non-significantly pancreatic fat content, and thereby is probably another very important agent that I would consider in using in people with type 2 diabetes and liver fibrosis. Talking about the cardiovascular outcome trials, and look at the dulaglutide trial, the REWIND trial. I'm just going to point out 3 important things. 9,000 individuals, the longest trial, 5.4 years. Baseline HbA1c, pretty well controlled. And then also you saw the cardiovascular benefit. Cardiovascular risk factor was present only in 31% patients. So they were more like the patients that you see in your clinic every day. 65% did not have cardiovascular disease, only had risk factors. And the HR hazard ratio was almost the same. And what did it show here? Similar hazard ratio, 0.88, 0.78, 0.74. But remember that all those trials had more patients with pre-existing cardiovascular disease. So they were more like the secondary prevention population trials. And so dulaglutide reduced cardiovascular both in men and women with or without previous cardiovascular disease and had an effect size similar to that observed with the other GLP-1 receptors, mainly in the secondary prevention populations. Now, dulaglutide is the first, the only GLP-1 to demonstrate benefits, both primary and secondary prevention of cardiovascular disease. And you can see here, overall 0.88, people who did have cardiovascular disease, 0.87, who only had risk factors, 0.87. So it reduces MACE events in adults with or without known cardiovascular disease. And that has been really updated in the ADA guidelines here. To date, the level of evidence to support the use of GLP-1 receptor agonists for primary prevention is the strongest for dulaglutide, but lacking for other GLP-1 receptor agonists. And there has been consistent benefit trials in patients with or without established cardiovascular disease. Talking about microvascular complications, we were talking about in Dr. Malik's talk also, and here is benefit of dulaglutide in eye complications, laser, anti-VEGF therapies, kidney, new macroalbuminuria, or 30% fall in eGFR, or chronic renal replacement therapy. The red line shows you dulaglutide and the blue is placebo. How do they do it? We all know how they work to reduce glycemia, working at the pancreas, decreasing hepatic glucose production, decreasing gastric emptying, improving, working at the brain, decreasing appetite, and also decreasing adiposity. But what about reduction in atherosclerotic plaques? Probably has an effect at the level of the endothelium and the smooth muscles and the macrophages, and on the regulation of plasma lipids, and thereby decreasing and the progression of atherosclerotic plaques. Inflammation also is very important, which it probably blocks. There are 3 GLP-1 receptor agonists available in India. The boxes ticked in favor of dulaglutide are the maximum, except that it's not oral, but people in several patient preference studies have shown that people prefer the once weekly injection versus a lot of limitation when using oral semaglutide and a daily injection of liraglutide, of course, with all other benefits which I've shown and enumerated, and also being the first and only GLP-1 for both primary and secondary prevention of cardiovascular events. So friends, type 2 diabetes is a cardiovascular renal disease. It comes with cluster of risk factors. The residual CV risk factor is always high despite good control. It's important to have a multifactorial approach in the reduction. Once weekly dulaglutide provides significant benefit by addressing multiple risk factors in people with type 2 diabetes. Guidelines recommend GLP-1s independent of baseline HbA1c when you have any of these things present there. And the size that it gives you, the effect that it gives you, is as good as agents which were used primarily in secondary prevention trials. And as I mentioned, it can be used for both primary and secondary prevention of complications and cardiovascular disease in people with type 2 diabetes. Thank you very much for your attention.
Thank you, Nigam, for a brilliant lecture. I should really congratulate you on that
Thank you.
lecture. And then you've very clearly taken us through the entire spectrum of how the GLP works and how once a week dulaglutide is going to change the entire treatment spectrum over a period of time. I think, in my presidential speech also today, I was just mentioning that India has different segments. The biggest problem that we face is we do accept that GLP-1 once a week is a great boon in the management of type 2 diabetes. But unfortunately, the cost becomes a big problem in a country like India, where the segments are different. I mean, even though we have a great drug, unfortunately, we'll not be able to use it in majority of the patients. And that is where the generics of SGLT2 are slowly trying to take over. How I wish the cost of once a week dulaglutide is going to be affordable by majority of the Indians. I mean, apart from that, every single thing that you said, we as doctors always say that I think this is the greatest discovery. And we have heard DeFranco speaking so passionately about the GLP-1s. And what is your personal experience on using once a week dulaglutide, and how many of your patients are on dulaglutide?
Oh, I probably have innumerable. And I probably have about, I would say, 6-7 prescriptions a week on dulaglutide once a week. And because of the obesity that you're now seeing mushrooming around India, I think several of them are also in combination with the SGLT2 inhibitors. But alone, a GLP-1 with basal insulin, a GLP-1 with a small dose of sulfonylurea, a GLP-1 with SGLT2 inhibitors, a GLP-1 with metformin, I think they're excellent combinations.
I know.
And I have to really emphasize the point that we are not treating only glycemia. We are preventing complications.
That's
so
true.
As I showed that cardiovascular risk factors today include age, hypertension, obesity, duration of diabetes. When you talk to a patient in the clinic, you say, oh, well, it's HbA1c is 7.9. I could get it down with any other thing. But what I'm trying to imagine is always, what is he going to do 35 years down the line? He's only 40 years of age. If he can afford, I know affordability, cost is a very important constraint and also a factor which I consider. And correctly chosen patients have been on dulaglutide or GLP-1s for 7 years, 8 years, 10 years. I have patients who are just vouch for it. I don't have to do anything because everything is under control. They've been able to reduce their weight, control. The blood pressure drugs come down drastically. If you put these patients on GLP-1 and they lose about 5 kilograms weight, and 3 centimeters of their waistline, their telmisartan dose comes down from 80 milligrams to 40 milligrams. Within 6 weeks or 10 weeks, one antihypertensive agent is knocked off. If he's on sulfonylurea or any other agent, those doses have to go down. So no, overall, it gets you many benefits. But the most important benefit is preventing patients from going to the hospital for a stroke or a myocardial infarction or even kidney disease. SGLT2 inhibitors are super agents. Again, I am a fan of both these agents. But then again, urinary infection, genital infection sometimes can be disastrous, as abdominal discomfort with GLP-1s is also there. So, it's really a balancing act and really trying to convince patients that these agents will have side effects. You have to choose which one, which helps you most, continue that.
Very true, very true. I think in all affordable patients, who can tolerate it well, I think GLP-1 should be the drug of choice, and especially with once a week injectables. I think even the geriatric population is something that, you can look forward to. And once a week is definitely, there is that affordable class in India. You need to just choose, maybe spend time and explain to them.
That's why all the Teslas and Mercedes and all are coming to India. That's the reason. Because the people can afford, people want that answer from you that this is the drug to use. They probably don't get it. And prescriptions are not written on time. And physicians, I'm not blaming anybody, physicians try to find the easy way out. Who's going to spend time on side effects? If he gets a nausea or a vomit, he's going to call me. Let him call him. You've got to be passionate. So that is something that hinders us from using these agents. Why do we use insulin? We use insulin. We know it causes hypoglycemia. And that's even worse. So, you could fall unconscious. So I think we'll have to really think about preventing complications rather than controlling only glycemia.
So I think the message is you shun the inertia and then look at your affordable class, and if you can be convinced, I think this is the drug to be started in most of your patients. Thank you very much, Dr. Nigam, for that wonderful lecture. I think we just exceeded the time limit by 2 to 3 minutes. Now I close this session here. Request Dr. Sanjay Reddy to take over